Well, I think that a question that's in the back of everybody's mind is what's the final recommendation going to be? What should policy be? And for the purposes of this panel, this session, I think you should think of yourselves as the decision makers for that. And what you have access to is a group of scientists who can tell you about the human evidence and what kind of information we might gather from the human evidence and how to interpret it and where we can go forward. So I'll open this to questions that anyone may have. Don't be shy. Okay, well then let me put quite some questions that we have from our online participants. For Marc, given that girls show symptoms differently from boys and conceivably leading to masking of symptoms, could the male-female differences be inflated simply because there's a lot of missing ascertainment in girls?
So with the caveat that I'm not necessarily an expert in all of this, I would say first that is true. I believe the symptoms are slightly different in boys and girls, and because these are very heavily social communication ones that frankly girls tend to do better on, I would say yes, it's certainly possible that some of that difference could be a sort of ascertainment issue, but there are also fundamental differences around this, like I believe there are more sort of dramatic genetic, and anyone here who knows more can correct me on this, but I think that the girls with autism tend to show stronger kind of genetic underlying reasons for a lot of the autism, or many of those cases, more of them are genetic. Maybe that's because we're missing some. So I guess it's possible. Personally, I would think be a little surprised if it accounted for the entire thing, but could it account for some of that difference? Okay,
so if we were to delve into the etiology and the pathophysiology, you would expect to see a genuine sex difference, at least as far as we can tell.
Yeah, I would,
so
and
far.
I mean, I would follow that also with the aspect that that issue of the microglial and the immune function role in brain development and potentially playing a role in some aspects of autism. There are a variety of exposures in animal models like stress, diesel particles, inflammation, that clearly show sex differences in the effects on microglia.
Okay.
So if that's playing a role, then I would expect that to actually be true.
Okay, and if I understood your presentation correctly, you see the microglia and the pruning as absolutely key to a physiology, which we're not going to talk about, but that's sort of where we're looking at in terms of an effect. And that could be either genetic or environmental.
Yes, I agree with that. I mean, I guess I was reacting a little bit about the absolutely key, because I think there are a lot of issues that are probably going on. I think it is likely to be an important one. Okay,
so some hyperbole. Dr. Lee, were you confident that the confounders that you used for adjustment were truly antecedent to acetaminophen exposure? So this is in the Alquist study, in the Swedish study. Were all the confounders... Are you sure that you didn't adjust for an intermediate variable there? I guess is the heart of that question.
Yeah, so that's a fair question. When we created our variables, we used timing, right? So we have the registered data available to us, and there are dates of diagnoses. So we made sure to not, for example, like migraine, to put that in, I believe, before pregnancy. I think antecedent conditions, people generally are more concerned with it, like for things like preterm birth, or small for gestational age, which some of the previous studies had done.
This is a difficult semantic and logical question, because for a chronically used drug, antecedent, well, you might mean antecedent to the pregnancy, but if something was an intermediate effect of the drug itself, it's still there and you've taken it before, and that's going to be tough. And this raises the question. You pushed very hard on the idea of the acetaminophen use as being a consequence of pain which was genetically caused, or could well have been genetically caused, and that changes the whole question of timing of exposure. Because if we think that somebody has a pain syndrome which is due to some underlying condition, then the acetaminophen use that you ascertained at week 10, even though you tried to ask for chronic, the precise timing of that confounded exposure doesn't really come into play anymore, does it? That if you've got pain and then the acetaminophen at week 10 is telling you something about acetaminophen at week 20 and 30 as well. So you wouldn't expect it to be a sharp point of exposure in that particular case of an alternative etiological pathway.
Right, so I think for health behaviors, genes aren't what you would call deterministic or highly penetrant, right? Like whether I reach for a pill bottle or not isn't written into my DNA.
But if pain is written into your DNA, then whether you reach for a pill bottle is sort of
right. I think I would classify it more as like a nudge, right?
A nudge.
Where like if there's like a coin flip, should I take, or should I, take acetaminophen? The genetics are in some way influencing that decision.
Okay, and we don't have a practicing clinician among us, so whether the pain amounts to a coin flip or a driver is something that we have to keep as a question to answer. Dr. Weisskopf?
I just wanted, because I wasn't clear on so that I think I agree with what Brian's saying, but I wasn't sure whether what your question was, that if you have a genetic condition that predisposes to pain for some sort, that is not going to influence when in the pregnancy you take
or you're going to be presumably using it throughout the pregnancy,
exactly. Right.
and it's still associated.
Right.
Associated, but through the confounding pathway rather than through a direct effect.
Yes, right. Yeah.
Okay. Please.
I'm curious to hear your thoughts on what length of follow-up is really needed, if we really need 8, 10, 14 years. And the reason I'm thinking that is given that the screening guidelines, we have systematic screening guidelines up through 30 months of age for a child, and then that largely stops, at least in the US. So I'm just wondering if you think that, like in terms of feasibility and the types of data we would need to collect, whether we could actually do a study through, say, 36 months and have some sort of insight there.
I think that was clear for the online listeners, but just briefly, does the length of follow-up, given current standards of diagnosis, could we do it at a shorter period, like 36 months, which also opens up other study possibilities? Krista and Sonia?
I can start, but then I'm going to refer to the expert, Marc, because only one study had the cumulative risk, and that was a study that didn't have a difference. So therefore, we cannot tell when we will see a separation, if at all. So I guess it will depend on if the increase were for very early childhood symptoms or neurodevelopmental aspects. Then we could see them early. The Swedish study had an average of 11-something years of a diagnosis. So if the potential effect we are talking about affected later types of autism, then we will need a longer time. So that's why I'm going to refer to Marc, like which kind of autism, early childhood or late, can be more genetic or more due to environmental things.
I hate to step in as an expert here, so I want to put a caveat on that one, but not necessarily be an expert. But what I will say is that, so diagnosis of autism, I think, has generally been coming down, so you can detect it earlier. That said, there are probably different types. I mean, as I said, it's wildly different in its presentation, and there may very well be different kinds from even an etiological perspective. It probably is expected that the genetic forms that are very driven by genetics are going to appear earlier, so if you only did 36 months, you're going to wait to those. Maybe others have maybe you know more about this. I'm still a little bit agnostic to whether if you focus on people at high genetic risk for autism, you're going to see more or less influence of a non-genetic factor, right? So, but it's certainly possible, and I think we even have some data where we sort of see slightly different things if you consider the later diagnosed people with autism. So I would be wary of stopping at 3 years. And not only would I rather go longer, I'd also like to sort of parse it a bit. Like, do you see different things if you look at people being diagnosed at 8 versus 3?
And I think from a different context, but some of the work that we've done, which was more focused on psychotropic medications, where we did look at the cumulative incidence curves, you see, at least in the US, you see to continue to generate like additional cases over time. So I think, yes, depending on when you stop, you might be missing a number of cases. And I think your question also goes into the feasibility. And I think one thing to keep in mind when we're thinking about other designs, which is more like prospective data collection and support, we're talking about an outcome that is pretty rare. And we're talking about, I mean, the effects that potentially have been seen are not that strong. So we're going to need very large number of pregnancies to be followed for a pretty long period of time, which I think is another consideration in terms of the feasibility.
Perhaps, I think Dr. Lee would, yes.
Just a very quick comment. Right now I think we're still in the stone age of autism research because we still think of autism as one condition, right? Like I think, for example, at some point with breast cancer, there's 6 or 7 different genetically defined breast cancers, which all have their own different prognoses and treatments and et cetera. And we're still lumping everything into one. And it's a very fair question that, there might be different autisms there that might potentially be responsive to acetaminophen, and we don't necessarily know. Which
Poses an alternative hypothesis for why a low relative risk for autism taken as a big lump might still correspond to a high relative risk for an appropriately defined disease. Maybe Professor Weisskopf is the best person to answer. Are we talking about the incidence of autism or the incidence of autism diagnosis in these studies?
I think we're talking about the incidence of autism diagnoses with the idea that we are making mistakes, absolutely.
Okay, and this sort of gives me some pause when I see all of us doing proportional hazards modeling, where if you had, for some reason, if you were to advance the age of diagnosis, which we agree is possible with under lots of circumstances, it's going to look like an increase in risk unless you have follow-up to the exhaustion of the final time of diagnosis.
Yeah, I'm actually really glad that you asked that because it's something that's been bothering me for a long time, and I would love to discuss more with people on this. I have been slightly concerned about doing autism studies with Cox modeling because of that issue, and not only because I think you're describing what is possibly a biological thing. But there's certainly in the past there's been huge issues about identification related to all sorts of other factors. When who gets diagnosed and who doesn't. In this country, for a long time, lower socioeconomic status was associated with less autism, which was almost certainly that they just weren't getting diagnosed as much.
Right.
And that probably also translates to if they get diagnosed later. So it might. So that is something I've struggled with, and I haven't come to a final answer on this, but it's made me worry.
So perhaps in response to the question, yes, in principle, with the right healthcare system, a short follow-up would work. But there's a lot of risk associated with this question of the time of diagnosis for a condition which may have been entirely determined by the time the person's born.
And I think this goes back to actually the suggestion that Sonia had made moving forward, that we really need these cumulative incidence curves, right? So far.
Yes, the cumulative incidence curve, and just look at the end of it, not how it's bumping along as it goes along.
And I think so far the Japanese study was the only one, given that there was a null finding, we couldn't really see whether there was any differentiation.
Yes, please, sir. Yes, please use the mic.
I'm really curious to hear the panelists' thoughts on the bar that a body of research needs to clear in order for us to say that a particular agent is traumatogenic. So earlier, Professor Weisskopf mentioned German measles, valproic acid, retinoic acid. the evidence for those being harmful to children in utero is so compelling that we're willing to make recommendations against their use during pregnancy. And so in those studies, we were willing to say that some of the maybe inevitable challenges of pregnancy-associated research, risks, exposure, outcomes, misclassification, etc., we're willing to say that those come in comparison to the strength of evidence. So I'm wondering, where is that bar in your point of view?
Could I rephrase your question by giving you a tool? So looking back at things that we're all agreed are teratogenic, do they have common characteristics, and how far are we from that at this point?
So yeah, thank you for the question. So with thalidomide, we are talking about 50-fold increased risk of something that is very characteristic. This is far, far, far from there. But at the same time, with 56% of women in the US using acetaminophen in pregnancy, any very small effect could have potentially many additional cases. So it's the perfect storm. We have something that is really hard to study, but potentially could result in many cases. So I don't have an answer for the threshold, like above this. Some epidemiologists 2 decades ago picked 2-fold increased risk. I think we have to lower the bar, or we are not going to say anything never. I think in pharmacoepi, usually when we start going to 1.2 or lower, we get very nervous about anything you do. It starts moving things, and it's not a magic threshold. But I have seen in environmental health, for example, when everybody is exposed and any little small effect may have consequences, they, I think, accept a lower relative risk. So I think it depends a little bit on the field. It's an interesting question, but I cannot give you a threshold.
Would Professor Huybrechts like to amplify?
Yeah, so what I would want to see is at least replication of like the finding in studies that we feel do the best they can in terms of trying to get a handle on potential confounding or misclassification. I think the situation we're in right now is that there's some studies that sort of suggest that there might be an increased risk, but they all have such fundamental problems in terms of potential confounding and misclassification. It's hard to see them as really replicating each other. So I think even if the relative risk is a little bit smaller, then maybe what would give us more confidence if we at least see replication in studies that do the best they can. It's clearly, as Sonia was mentioning, it's a very complicated situation in order to try and really get that exposure definition properly defined, but that would be sort of my sense.
I'm putting together Professor Lee's comment with Professor Hernández-Díaz, since she pointed to thalidomide, where you have a 100-fold increase of an otherwise unseen condition, and you have what generations ago was called a moral certainty that something's going on here in public health terms. And the question was, would there be a sufficiently discriminative classification, ideally based on pathology, of different ASD types that you could possibly see an effect? That would be one hope for seeing an elevated effect, maybe not a thalidomide level effect, but an elevated one if it was there. Maybe the other side is asking, when are you comfortable saying that in your view, there's really nothing going on here? Would a sufficient number of sibling studies at least allow you to say that for high-risk families, there's pretty good evidence that there's no effect of no causal effect of acetaminophen? Can you imagine? Let me ask Professor Lee. Can you imagine a point at which you're okay? You tell your daughter or your cousin, fine, if you've got a fever, take your acetaminophen.
Well, let me reframe it this way. At what point would the field be okay with, we've studied enough? Like for for example, for vaccines in autism, studies are still coming out even as recently as this past year that showing that vaccines don't cause autism, right? And so I think this is something that different people are going to have different thresholds for. Okay, I've made up my mind, and the other people won't be convinced until like the 40-second study comes out on this topic showing a no effect.
I think vaccines is an excellent example of something where the community of people who study these things really is comfortable that there's no effect of vaccination on autism. And there's all kinds of pathophysiologic reasons and sort of observational reasons for saying this is very unlikely, although I'm taking on board Professor Weisskopf's pointing out that postnatal remodeling, of course, goes on. And so when I was thinking about vaccines, I really hadn't thought about that at all as a possible justification. But I'm still confident that it's not causal.
So the other point I think that is important to keep in mind is when we're trying to decide, like, okay, is there this threshold? Is like, it is not just an assessment of risk, it's a risk-benefit trade-off that clinicians also need to make in actual practice, right? So there's like, is there a potential risk, and will we ever be able to reach a point that we can be absolutely certain that there's none? Or is it like, do the benefits outweigh the risks? And here we're talking about...
I think it's an excellent example. And the example that Sonia gave of triptans as the alternative. If you're a migraineur, and somebody says, well, just don't take any pain medicine for the next couple of months, you'll be okay. That's really not proper doctoring. Mm-hmm. So we have to consider the alternatives. I'm sorry, Sonia?
A question to you and to the biostatisticians in the room. Can we prove the null? Is that possible? Can we prove that drinking water in pregnancy is not bad for anything? So I'm pushing that it's an exaggeration, but in the sense that usually for medication safety in pregnancy, we try to have boundaries of safety around the risk, not necessarily know that we can show that there is absolutely no risk, never for anybody, but that we can rule out with certainty that this is a thalidomide or that this has a very, very large risk.
Yeah.
So is there a different...
Well, we're public health scientists, so it's not, it's optimal conduct is, the best we can shoot for. We can't prove that something doesn't happen. I mean, as you were implying. And that's where the risk-benefit issues come in. And what's the consequence of making a pronouncement in terms of harm?
Yeah, so
I'm
sort of also to get back to your point, I mean, I agree with Sonia totally, and I think others have stated this. I mean, I think different people are going to have different bars, there's no question. There are a lot of issues that were described here that I want to touch on, and I'm probably going to forget some of them. But let me start by saying, like, even I come from environmental health where we deal with very low effect estimates, but very widely exposed populations. I personally feel, looking at all the literature now, as much as I have, and I'm there's more I could dig into in this topic that I haven't, I am at the place where I would not say to change any recommendation. I mean, what you put up there about use it to, as needed, as less as possible, is absolutely where I would be now. In terms of the discussion of, like, can we prove the null? And, like, even the vaccine study, right? There does come a point where so many studies have been done on vaccines that the consensus has been reached at a certain point. I feel, personally, as a scientist, that part of being a scientist is always being open to the idea that you're wrong. And so what is important to me is I can come to a decision on that and say, I think it is a slam dunk. If somebody comes to me and says, there's a bias in here you and no one else have ever thought about, I will re-engage. And I will say, okay, well, let me try and say that that's not happening. We need to investigate that, right? So I think these things changes, and we shouldn't set it as an absolute, but we do have to make decisions. And certainly right now, in terms of this topic, I would not call it, I would be nowhere near saying acetaminophen causes autism yet. Do I have some things that as a scientist give me a bit of pause? And do I want to see something else? Yes, and we can delve into those. And I noticed that Sebastian left, and he asked the question about what we would want later, but we can get to that. So that's sort of where I where I stand, but I even and I think it's also added to the fact that we might get more information on different types of autism, and it may turn out that we actually are going to get fingerprints of very different things with different etiologies, and now we understand that this one over here, there's a huge effect, right? So I think we should always be open for that, but if someone comes to you with new information, you need to then decide, does that actually change my thinking, or do I still think the same? But certainly there's points where we get to a stage where we have to say,
Miguel Hernández had his hand up for a bit.
Thank you. I have a question with two parts. The first part is, we have seen in some of these studies that the associations, whether they are causal or not, with autism are very similar for acetaminophen, NSAIDs, ibuprofen. Why are we talking about acetaminophen only? That's one question. And then the second part of the question, which is related, is given that during pregnancy a woman who has headache has to take something, why all these studies compare acetaminophen versus nothing as opposed to acetaminophen versus ibuprofen? That seems to be the right comparison. We would never compare. If we were studying the safety of an antihypertensive, we wouldn't compare antihypertensive use versus no use of any antihypertensive. Why is this happening here?
I'll say one thing quickly, but then you guys probably have a
I
lot
think
more to say on
Sonia
this.
went to answering that question. Please.
I mean, I think you could jump in too. I will just say that, I think a lot of those other medications are counterindicated during pregnancy. So there are valid reasons not to take them, right? Acetaminophen then also has this issue of a reason, my understanding, and I'm not an expert in this, is that it's got a narrower window of toxicity so that you can get up to toxic levels faster than other things, and so there's reasons to be concerned about it. It can be exacerbated by alcohol, for example, for liver toxicity. So one issue is why are we looking at acetaminophen? I always thought it was that. I don't know enough about the other medications other than I thought they are counterindicated in pregnancy for other reasons.
And Sonia set up, though, her ideal study was where some kind of analgesic was strongly indicated, people with migraine. So
So two questions, two answers. For why acetaminophen, I think there may be biological plausibility reasons, but I'm going to provide another more practical reason, is that because it has been recommended in pregnancy, the use is 50% or above if you consider over-the-counter and any irregularity. So more studies are going to have more numbers than if to consider, say, ibuprofen, aspirin, or even or triptans. So I think more people will have more data to look at acetaminophen with anything, even when it is challenging. And in part because aspirin, ibuprofen have been contraindicated at different types of pregnancy for different reasons in different populations. So I think the practicality of numbers is another consideration. And then why versus indication, even when I was the one saying, and of course we will consider the indication, looking back at the literature, including my studies, we didn't consider indication for the longest time. And I think the rationale that we told ourselves is that the indication could not affect malformations or autism itself. And maybe if you think about genetics, so we said, okay, perfect. We have a natural experiment. And like everybody else, we don't have to worry about indications. And a clear example was SSRIs some years ago, like SSRIs versus not SSRIs, because why would depression increase the risk of cardiac malformations? And then until Krista did the study showing that when you restrict to depression, the 1.2 something goes to 1. And we were like, oh, maybe we do have to also worry about indication, either because of direct effects or because of genetics or other things. So I think in the field, in pregnancy, comparing exposed with unexposed has been very common, including myself.
I think the idea of a shared genetic architecture between a potential indication and an outcome is something that's going to force us to really think hard about a lot of things we've sort of casually said about confounding by indication so far. I mean, it just adds another dimension that is going to be important. Krista.
And I think another reason why historically, like a lot of the studies would have compared like exposed to completely unexposed, even though it does not really address a relevant clinical question, is because like for many medications, we don't really know whether they're safe or not, right? So yes, you can then answer questions about comparative safety, but like if there is concern that maybe the medication you're comparing to also has some increased risk, you haven't really tried to assess that absolute risk. And I think that's historically why that also has happened a lot in the past. It's like to try and get, like, is there an absolute increase in risk, not relative compared to other medications, which does not really address an important, the clinical decision that needs to be made. But I think historically, that's also where.
Yeah, I think that prior to this positive use of target trials as a way of thinking about design, we were also enslaved a little bit by ideas, by being taught that all science is randomized trials, and then we're thinking of one versus the other. I think we're getting free from that, but there's a lot of heritage of simplistic thinking.
Yeah, so one comment yours, and then I do want to raise an issue that I.
And yours is the last issue, because then we're at the end.
Okay. I mean, the other just piece of what your question that you're asking is one of those little things that still gives me a little bit of pause, which is using, and we can have more discussion, and I haven't thoroughly thought this through, about using these other medications as other negative controls, is that they're indicated, the people using them are using them for very specific reasons if they're counterindicated. So is that really an appropriate negative control? I'm not so sure, because it's a very specific type of person who's going to use one of those during pregnancy. So that's one issue.
Just a clarifying comment, like for NSAIDs, I believe they're contraindicated only in the third trimester, just because of the malformations aspect.
Okay.
Whatever outcome they're associated with.
So, well, that brings me to the other point that I would like
No, but it's an important question. I mean, it's not just another drug. It's another drug taken against medical advice. And maybe that's added to another level of causality. We're at the end of our time. I want to thank those online. I can't see you, but I've appreciated your questions and your participation, and everybody here in the room. And I want to thank our panelists, some of whom have traveled a good distance to be here, and all of whom professionally have traveled a good distance to
Can I raise one
here.
issue before we end?
Please say one thing.
One thing that is that even if the sibling analysis is working perfectly, doing everything we ask it to do, if you're looking at the wrong exposure, it is going to give you a null result. So we didn't talk about, but I do think it is worth thinking. It's not, I still would not say this is causal at all. And one of the things that gives me pause is timing may be relevant. And in your paper, 80% of the use was in the first trimester. If the timing that matters is the third trimester, we're not going to see it. So it will find confounding and it will get rid of confounding, which I fully believe is there. But the fact that you're getting rid of confounding does not, by per se, mean that there isn't also an effect. And if the window you're looking at is wrong, you're not going to see an effect.
Dr. Lee's articulate and well-thought response is going to have to hang in the air, because we're done with this session, but I think this is a discussion that we can continue at the reception afterwards.
All right.
Thank you very much, everybody.